Welcome back to Pediatric Case Review. Today we're working through Hunter syndrome, Mucopolysaccharidosis Type 2, across 15 clinical questions built for the general pediatrician. Would you spot it in a toddler boy with recurrent hernias and a hoarse voice before the diagnosis is obvious? We'll cover recognition, genetics, the eye finding that separates it from Hurler, the workup, enzyme replacement therapy, and long-term prognosis. Let's get into it. Question 1. A 3-year-old boy with 2 prior inguinal hernia repairs, recurrent ear infections, and a new hoarse voice. On exam, coarse facial features, broad nose, thick lips, hepatomegaly, mild joint stiffness. Importantly, he's developmentally appropriate. Look at the 4 options: Hurler, Gaucher type 1, Hunter, and Sanfilippo. Which fits best? The answer is C, Hunter syndrome, MPS 2. It's X-linked recessive, so it affects almost exclusively males. The classic triad is coarse facies, hepatomegaly, and joint stiffness. The red flags that should make you think MPS in a toddler boy are recurrent hernias plus a hoarse voice. And here's the key parole that separates Hunter from Hurler: no corneal clouding. MPS 1 has prominent corneal clouding. MPS 2 does not. Sanfilippo is dominated by behavioral and cognitive decline, with mild somatic features, and Gaucher doesn't give you this coarse facies picture. Question 2. A 4-year-old boy with coarse facial features, short stature, and progressive joint stiffness. His mother has a brother with a similar condition. His own sister and mother are unaffected. Look at the pedigree: an affected maternal uncle, a carrier mother, an affected boy. Which inheritance pattern fits? The answer is A, X-linked recessive. Hunter syndrome is caused by mutations in the IDS gene on chromosome XQ28. It almost exclusively affects males. Females are typically carriers. A carrier mother has a 50% chance of passing the affected X to each son. And the hallmark of X-linked inheritance: no male-to-male transmission, because fathers pass a Y to their sons. The affected maternal uncle plus the unaffected parents is the classic X-linked pedigree. Question 3. A 5-year-old boy with MPS 2 has his annual ophthalmology exam, and the corneas are noted to be clear. The question: what's the clinical significance of that finding for telling MPS 2 apart from MPS I? Read the 4 options carefully. The answer is D. The absence of corneal clouding is a distinguishing feature of MPS 2 versus MPS 1. In Hurler, corneal clouding is a prominent early finding. In Hunter, the corneas stay clear, and that's a genuinely useful bedside discriminator. Don't be falsely reassured, though. MPS 2 can still cause retinopathy and optic atrophy, so the eye is not spared. It's just the cornea that's clear. The clinical pearl: clear corneas in a boy with coarse facies, should make you think Hunter. Question 4. A 6-year-old boy with Hunter syndrome undergoes cardiac evaluation. Which cardiovascular finding is most associated with MPS 2 and contributes significantly to morbidity and mortality? The options span VSD, coarctation, valve regurgitation, and complete heart block. The answer is C, mitral and/or aortic valve regurgitation from GAG deposition. Valvular heart disease is the dominant cardiac problem in MPS 2. The mitral valve is most commonly affected, then aortic, then tricuspid, then pulmonary. The mechanism is glycosaminoglycan deposition in the valve leaflets, causing thickening and dysfunction. This matters because cardiac disease is a leading cause of death in MPS 2, so an annual echocardiogram throughout life is essential. Never skip the echo. The structural defects in the other options aren't features of this disease. Question 5. A pathophysiology question. Which enzyme is deficient in Hunter syndrome, and which glycosaminoglycans accumulate as a direct result? Look at the 4 enzyme and substrate pairings. The answer is A. Iduronate 2-sulfatase, I2-South, is deficient, and dermatan sulfate plus heparan sulfate accumulate. The IDS gene encodes this lysosomal enzyme, which cleaves the 2-O-sulfate group from both dermatan sulfate and heparan sulfate. When it's missing, dermatan sulfate accumulation drives the somatic features: bone, cardiac, joints. Heparan sulfate accumulation drives the CNS involvement and neurodegeneration. Contrast with MPS 1, alpha-L iduronidase, and MPS 6, aryl sulfatase B, which stores dermatan sulfate only. Question 6. A 7-year-old boy with severe Hunter syndrome develops progressive behavioral problems, aggression, and cognitive decline. The question: what is the primary mechanism responsible for that CNS deterioration in severe MPS 2? Think carefully through the 4 options. The answer is C, communicating hydrocephalus from meningeal GAG deposits, combined with direct neuronal heparan sulfate storage. 2 processes act together. First, heparan sulfate stored inside CNS neurons causes direct neuronal dysfunction and death. Second, GAG deposits in the meninges impair CSF reabsorption, producing communicating hydrocephalus and rising intracranial pressure. A crucial therapeutic point: standard IV idursulfase cannot cross the blood-brain barrier, so it gives no CNS benefit. In the severe form, cognitive regression typically begins around age 6 to 8. Question 7. A 2.5-year-old boy with coarse facial features, joint stiffness, hepatomegaly, and recurrent upper respiratory infections. You suspect a mucopolysaccharidosis. Which investigation should be ordered first? The choices are skeletal survey, brain MRI, urine GAG analysis, and echocardiogram. The answer is C, quantitative urine glycosaminoglycan analysis. This is the first-line screening test. In MPS 2, it shows elevated dermatan sulfate and heparan sulfate. A positive screen is then confirmed with an I2 South enzyme activity assay, and once the enzyme deficiency is confirmed, IDS gene sequencing identifies the mutation for family counseling. The skeletal survey shows dysostosis multiplex and is an important part of the workup, but it's not the first diagnostic step. One caveat: also test a second sulfatase to exclude multiple sulfatase deficiency. Question 8. Urine GAG analysis in a 3-year-old male shows markedly elevated dermatan sulfate and heparan sulfate. Which test is most appropriate next to confirm Hunter syndrome? The options include enzyme assays for the wrong enzyme, gene sequencing alone, and urine oligosaccharides. The answer is B, IDURON8 2-sulfatase enzyme activity in leukocytes or plasma. This is the gold standard confirmatory test for MPS 2. It can be performed on plasma, leukocytes, or a dry blood spot. Very low or absent ID2 self activity confirms Hunter syndrome. Always also test another sulfatase to exclude multiple sulfatase deficiency. IDS gene sequencing then follows for mutation identification and family counseling. Option A is the enzyme for MPS 1, and gene sequencing alone without enzyme confirmation isn't the standard next step. Question 9. A 4-year-old boy is newly diagnosed with Hunter syndrome. As part of the baseline workup, which single investigation is most important for assessing cardiac status? Echocardiogram, plain chest X-ray, Holter monitor, or cardiac catheterization? The answer is A, echocardiogram. A baseline echo is required at diagnosis in all MPS 2 patients. It assesses valve morphology, ventricular function, and wall thickness, with the mitral valve most commonly affected, then aortic, then tricuspid. Annual surveillance continues throughout life because cardiac disease is a leading cause of death. Remember, the baseline workup is broader than the heart alone. It also includes ECG, audiogram, ophthalmology, skeletal survey, pulmonary function tests, brain MRI, and developmental assessment. Question 10. 2 brothers, both diagnosed with MPS 2. The 4-year-old has coarse features and joint stiffness, but is cognitively normal. The 9-year-old has intellectual disability, behavioral aggression, and seizures on top of the somatic features. Same diagnosis, different stories. Which statement best describes Hunter syndrome phenotype classification? The answer is D. The neuronopathic severe form is defined by progressive CNS involvement, while the attenuated form has minimal CNS disease. This is the central concept. The neuronopathic form brings progressive cognitive decline, behavioral problems, seizures, developmental regression around age 6 to 8, and death typically in the 1st to 2nd decade. The attenuated form has normal or near normal intelligence, somatic disease only, and survival into adulthood. Note the caution: enzyme activity level alone cannot reliably predict CNS involvement. Genotype gives only partial guidance, and corneal clouding doesn't separate the forms. It's absent in both. Question 11. A 3-year-old boy with coarse facial features, enlarged liver, joint contractures, and an inguinal hernia. What most helps distinguish MPS 2 from MPS 3, Sanfilippo? The options test intellectual disability, behavioral problems, somatic versus CNS balance, and hearing loss. The answer is C, prominent somatic features in MPS 2 versus severe CNS disease with minimal somatic findings in MPS 3. This is the key discriminator. Hunter has a prominent somatic burden, coarse facies, hepatosplenomegaly, joint contractures, hernias, with CNS involvement only in the severe form. Sanfilippo stores heparin sulfate only and is dominated by severe CNS disease, behavioral chaos, and intellectual disability, with only mild somatic features. The clinical rule of thumb, big liver, joints, and coarse facies point to MPS 1, 2, or 6. Behavior and cognition dominating with mild somatic disease points to MPS 3. Intellectual disability and behavioral problems occur in both, so they don't separate them. Question 12. A 5-year-old boy with confirmed Hunter syndrome, attenuated phenotype, is about to start disease-modifying therapy. Which is the only FDA-approved enzyme replacement therapy for Hunter syndrome, and how is it given? Look carefully. Some options are real ERT drugs, but for other diseases. The answer is A, idursulfase, brand name Elaprase, given as a weekly intravenous infusion. It's the only FDA-approved ERT for Hunter syndrome, approved in 2006, dosed at 0.5 milligrams per kilogram IV once weekly. It reduces liver and spleen size, improves joint mobility, and stabilizes pulmonary function, but it does not cross the blood-brain barrier, so there's no CNS benefit. Pre-medicate with antihistamines, with or without corticosteroids, for infusion reactions, and best outcomes come from starting before age 8. Loranidase is for MPS I. Galsulfase is for MPS 6, and serlipinase alpha is for CLN2 disease. All distractors here. Question 13. Parents of a 6-year-old boy with severe Hunter syndrome ask whether idursulfaxin will help his cognitive decline. What's the most accurate statement about standard ERT and CNS manifestations? The answer is B. Idursulfase does not effectively cross the blood-brain barrier and has limited benefit for CNS manifestations. This is the honest counseling point for families. Standard IV ERT is too large a molecule to cross the barrier, so it improves somatic disease, joint mobility, organ size, respiratory function, but cognitive deterioration continues unaffected. It does not reverse decline, and it isn't contraindicated in the severe form. It's just limited there. Emerging CNS-targeted approaches include intrathecal ERT, palbinafusp alpha, approved in Japan, and gene therapy in clinical trials. Question 14. An 8-year-old boy with severe Hunter syndrome has progressive noisy breathing, frequent nighttime apneic episodes, and worsening exercise intolerance. Polysomnography confirms severe obstructive sleep apnea. What's the most appropriate initial intervention? Tracheostomy, a mandibular advancement device, adenotonsillectomy, or systemic corticosteroids? The answer is C, adenotonsillectomy. Obstructive sleep apnea is essentially universal in MPS 2, driven by macroglossia, enlarged tonsils and adenoids, and GAG deposits throughout the airway. First-line management is adenotonsillectomy, which improves but rarely fully resolves the OSA, so CPAP or BiPAP is often still needed postoperatively. Tracheostomy is reserved for advanced refractory disease, not first-line. And a critical safety point, all MPS 2 patients have a difficult airway and high anesthesia risk, so a mandatory preoperative airway assessment is essential before any procedure. Question 15. A 10-year-old boy with severe Hunter syndrome has been on idursulfase ERT for 4 years. His parents ask about long-term prognosis. Which statement is most accurate? The options make claims about survival, the attenuated phenotype, causes of mortality, and whether ERT prevents cognitive decline. The answer is C. Cardiac disease and respiratory failure are the leading causes of mortality. In severe MPS 2, death typically occurs in the first to second decade. On the cardiac side, valve disease and cardiomyopathy progress to heart failure. On the respiratory side, airway obstruction and restrictive lung disease drive failure. ERT improves somatic outcomes but does not cure the disease or fully prevent progression. The attenuated form is not uniformly fatal before 20. Those patients survive into adulthood, though with significant morbidity. And early ERT does not fully prevent intellectual decline in the severe form because the drug doesn't reach the brain. Before we wrap up, if these case-based reviews are helping you, join the Pediatric Case Review community. Every video is organized by body system, so you can find what you need instantly. and all presentations are available as downloadable images for offline study. Comment below or subscribe, and we'll message you directly. New cases go up every week. Let's consolidate Hunter syndrome into 6 takeaways. 1. Inheritance. X-linked recessive. IDS gene on XQ28. Almost exclusively males. 2. Red flags. Coarse facies, hernias, hoarse voice, and joint stiffness in boys aged roughly 1.5 to 4 years. 3. Diagnose with a stepwise approach. Urine gags, then I2-sulfate enzyme activity, then IDS gene sequencing. 4. ERT with idursulfase gives somatic benefits only. It does not cross the blood-brain barrier. 5. Monitor annually. Echo, ENT, ophthalmology, pulmonary, and developmental assessment. 6. The leading cause of death is cardiorespiratory failure, so multidisciplinary care is essential. Thank you for learning with me today. A reminder that these lectures are educational and don't replace current guidelines or specialist input. Always consult those for real clinical decisions. The key references are on screen, including the Gene Reviews chapter on Hunter syndrome, Nelson Textbook of Pediatrics, and Up to Date. If this review was useful, follow Pediatric Case Review for more case-based pediatric lectures, and leave your questions in the comments. See you in the next one.